I recognise a couple of you from fifth year. I think maybe you saw me doing the CBL teaching, possibly the CBT teaching as well. Nice to see you. Like I say, well done getting through this disrupted year and the disrupted year before it. Did anybody miss their Psych Med run last time because of COVID? No, that's good. We had a couple of people last time who missed the Psych Med run last year and this year. So that was a bit of a challenge for them. So good to see that you've all got some Psych Med experience. So today is the intro to the Psych Med run. So I'm going to tell you what to expect in terms of what we're looking for in terms of the experience you're going to get, but particularly what we're looking for in terms of the examinations you're going to be set. It is a bit tricky this time for you guys because it's the last run of the year. We're going to be doing the exams. We normally do the exams in the final week, but this time we're going to be doing them in week 3, which puts a bit more pressure on you guys. Maybe it'll make you feel better, but the last 2 runs have been 3-week runs, and they've got everything done in 3 weeks. So I'm not overly concerned. We had everybody pass in the last 2 runs. But pretty much you're going to be examined in week 3. There is added pressure in that it's the last run. So we've been told by the university that we need to get the marks in by the Monday after your exams. If anybody needs to resit, there's not going to be any time to resit. So that's going to cause major problems for graduation. So no pressure, but we really, really want everybody to pass this time if we possibly can. We are going to be make reasonable adjustments, should we say, reasonable. We're going to understand that when you come to Viva time, but I'm going to try and prepare you as best as we possibly can for that. Okay, so what I'm going to do is I'm going to share my screen. Let me know if you can't see what I'm about to share. Okay. Okay, everyone see that? Thumbs up? Brilliant. All right, so I'm just going to go through what to expect from this 4-week run. I haven't even introduced myself, have I? So my name's Paul Skirrow. I'm a convener for this course, senior lecturer here. I'm also a clinical psychologist, which does mean that I am not so good on medications because I don't prescribe, but I am particularly good on psychological therapies. So I'm a clinical psychologist rather than a psychiatrist, but obviously all of your placement tutors will be psychiatrists. Okay, so what we're expecting from so you're going to be PGY1s very, very soon. And so what we've been looking for all this year really is to try and translate some of that book knowledge into real world knowledge that you can apply when you're PGY1s. And so that's what that says there, individual clinical reasoning, applying it to real people. And the way we want you to do that is to basically spend as much time as you can on placement. And we've got a bunch of tutorials which are designed to help you apply that to individuals. So you've got 4 tutorials, including this one. So you've got one on psychopharmacology, one on psychotherapy, and one on kind of medicine, so kind of psychiatry presenting in medicine, so in GPs and EDs, so kind of consult liaison type stuff. And we've introduced a 4th one as well, which is an exam preparation one, which is they're all run by our registrars, and we've introduced that because we acknowledge that the Viva this time is quite hard, and I'll go into that in a little bit. So there's an extra tutorial which is optional for you to practice. But those 3 main tutorials are designed. We want you to bring clinical material to those, so we can talk about your cases and try and figure out the stuff you've read in books and stuff you've read online about how those apply to those individual people. So they're less talky and more discussing your clients. So obviously you'll all have supervision on placement. We'll be expecting you to discuss the patients that you see. Should be having an hour a week with your supervisors and discussing patients from a biopsychosocial perspective. You should all know what that means. we will talk a little bit more about what it means in terms of a formulation, but you should remember that from 50 here. We are trying to get you to develop the frameworks for considering management. We are obviously your TIs. We're not expecting you to know absolutely everything about every psychological therapy, just to have the framework and the reasoning to be able to say, this is where I would ask my consultant. So we just want you to have a good idea about where you're starting from on this placement. It is a really short run, and I am part-time. I'm 2 days a week. So if there's a problem, we need to know very, very early, because we have no chance of sorting out if we don't hear about it until the week of the exam. So please do tell us if there are any problems. Best person to contact is Kerry, because she's pretty much full-time, and she can get in touch with me if she needs to, but she's got most of the answers. Yeah, so ensuring adequate knowledge was the other point. Okay, so in terms of your clinical work, you must see and discuss the management of a suicidal patient, which if you're in a DHB, which you all are, will not be hard. That's kind of the bread and butter of DHB work. Similarly, a patient with schizophrenia, depression and bipolar affective disorder, all very common cases that you'll see. Clinical pharmacology of major mental illness, you can't miss out on that, really. That's a large part of what the psychiatry teams do, and you will have an extra tutorial on that. You've also got to do some on-call, so one evening and one weekend during your rotation. Yeah, not much more to say about that, except for if you're in Wellington, Kerry will send out a sign-up sheet for you to sign up to the right time. I don't know if she's done that already. If you're outside of Wellington, basically you arrange that with your supervisor. So that's where you see the kind of the sharp end stuff. That's the quite literally sometimes. So people with serious self-harm and crises and suicidal behavior. So it's really important that you see some of that work. It's not all of psychiatry, but it is a big part of it. So we expect you to present 2 case histories to your clinical supervisors. And what we want is things to follow through. So we're trying to get you to see on this run a very small number of people. We're not asking you to see thousands of people like you might in A&C. We're trying to get you to see a small number of people and really get your head around and really think hard about those individuals and how the literature applies to them. So ideally, these would be the same people. Ideally, you would see some people, and we're going to talk about what you do with those people in a little bit. And then you would present those case histories to your supervisor, and then you would write a formulation based on that person. I know you did formulations in 5th year, but we're going to go back over what those are. But it's expected that you guys, you're nearly PGY1, so we're expecting you to be proactive and seeking out opportunities with other health professionals and patients. And you kind of have to do that because all the teams are busy, and COVID's probably made that worse. So these things may not be handed to you on a plate, so it's up to you to kind of go out and try and get the best experience you can. So examination, the things you need to do to pass. We have a recovery reflection, which is based on the World of Difference teaching you're going to have today. It's a very short piece. It's about a page long, thinking about reflecting on the process of recovery and the psychiatric system based on what you're going to hear today. That is an interesting one because it's hard for some people because there's no kind of right answer. It's not a factual based thing. It's more about how you've reflected on what you've heard. So we ask people, and Tracy will go through this with you, ask people to get that in quite early, because then it gives us a chance to give you good feedback, because people sometimes struggle on that. You'll hear more about that soon, but the 360-degree assessment is basically the idea is having an all-round view of how you're performing. So in the past, it was very much you were evaluated by your supervisor alone, and it may be that your supervisor was very old school and did things in a certain way, and then you do things in the same way as your supervisor, and it would kind of perpetuate. As you'll hear from the World of Difference team, there is a movement to be more collaborative with clients and people with mental distress themselves. So we're trying to look for an all-round view of how you're performing. So to do that, we have some forms you need to fill out. So one is a client feedback form. So when you meet with a client, you ask them basically how you did in 4 domains, and there's 3 of those. There's 3 colleague feedback forms, so asking members of the team what they thought about your performance, and 2 observed interviews where your supervisor sees you interview some people. Now, in an ideal world, those would be the same people. So you would do the interviews with people, and your supervisor would observe you for one of them. You would get the feedback forms from those people. Then you would present them as case histories to your supervisor, and then you'd write formulations on them and be examined at the end. Ideally, it'd be the same people. It's not always possible to do that, but we don't want to give you extra work. It's about thinking about a small number of people. Yeah, you've got to complete a PASAF. Well, your supervisors have to complete a PASAF. They're supposed to do it with you. They don't always. Sometimes they forget and do it at the last minute, as we all do these things. But that will require you chasing them, because they're very busy people and they often don't get things in on time. It's really in your interest that they get things in on time. So those all really need to be with us by the end of week 3, just so we can sign you off for the university for week 4. So you all know about PASAF. And then there's the Viva, which is the big thing. We have recently brought all 3 schools, so Dunedin, Christchurch and Wellington, all into line, so we do things the same. Now, we always used to do 20-minute Vivas, but we've recently come into line with Dunedin and Christchurch to make them 10-minute. So they are very, very short and very, very sharp and quite difficult. We have quite a lot of people who really struggle with this. So preparation is key. We seem to have done a little bit better the past couple of times, and I'll hopefully tell you some top tips later on. But we have had quite a few people need to resit over the year. So it follows a pro forma, so 4 domains. So you will submit your 3 formulations on the Wednesday of week 3, and then we'll read them on the Thursday, and then on the Friday we'll examine you, and based on one of those formulations we will ask you to present your preferred and differential diagnoses for that person. We'll ask you about risk assessments and risk and safety issues for that person. We'll ask you about cultural, psychological and social factors, which is largely your formulation, but it's a little bit wider. We'll talk about that in a bit. And then we'll ask you about management. And we'll talk about all of these things in a bit. So it's diagnosis and differentials, risk assessment, cultural, social and psychological factors, and management. So those 4 areas. So you know what's coming. So with your 3 formulations, you need to think about all of those domains. And it is 10 minutes long, which gives you 2 minutes to talk about each pretty much. And so be prepared. I recommend that people have a little script in their head for each of those things, because you know the questions are coming, so you should be prepared for them. And that's pretty much it. That's pretty much all you need to know about what we're going to about the examinations and about the papers. We're going to do a little bit of talking about the process of the Viva and some kind of top tips and a little bit of practice, a little bit of a refresher from 5th year for the rest of the time. And I do want to give you a break before you go into the World of Difference teaching. But that's basically the framework of what you need to know about the Psych Med run. Are there any questions at this point? No, fairly clear. Obviously, we're going to keep going, so you can ask me later on. So what we're going to do is we're going to talk about diagnosis and formulation. I'm going to touch on risk assessment. I'm not going to talk an awful lot about management. The reasoning behind that is what you're going to be doing on your run is you're going to be on your placements is you're going to be observing a lot of management. You're going to be seeing how your supervisors and registrars do the management. But we're going to talk specifically about diagnosis and formulation, just as a refresher from last time. I'm going to say it lots of times, but there's some good stuff on Moodle to get you prepared, particularly around formulation and risk assessment. So there's a good how-to guide on formulation, and there's a good little summary, some little videos and things on things to remember when you do your risk assessment. Risk assessment is often one that people fail on in the Viva because the Vivas are really about making sure you're safe. And if you miss something on the risk assessment, then it's hard for us to consider you safe. So that's one to be really prepared for. Like I say, preparation is key. If you just turn up and you're like, and somebody says, you know, what are the risk issues? And you go, I guess. Yeah, that's probably not a good idea because making up on the spot's not a great strategy. Okie dokie. So let's talk about diagnosis. And here's an example that one of my predecessors came up with, which is a real case, I believe, and kind of typical of the kind of people you'll meet on your Psych Med run. So this is Janine, and Janine is a 21-year-old of Maori descent. Her mother brought her up after her father abandoned the family when Janine was 3. Janine's mother was treated for depression around that time and subsequently had to go out to work. Janine was often left on her own or on the marae. Janine often saw her mother's boyfriends be abusive to her mother verbally and physically. Although academically gifted, Janine grew up with poor self-esteem, struggled in the classroom and had few friends. She became pregnant at 16 to one of the many brief, intense relationships she had. She left home and school thereafter and had difficulty bringing up her daughter, who's frequently ill and hospitalized, leading to the attention of child welfare agencies. The child's father is sporadically present and attempts to support Janine and their child. Despite their efforts to help, Janine perceives all but one social worker as putting her down and telling her she is a bad parent. She presents now with a 3-month history of general ill health, tearfulness, lowered mood, insomnia, anorexia, weight loss, and an inability to cope. She took an overdose of 12 sleeping tablets yesterday evening, which was only discovered when her child's father dropped by coincidentally. Her most recent boyfriend of 6 months had left her 8 weeks earlier. Janine thinks she may be pregnant. Okay, so a bit of a difficult situation there for Janine. Okay, so what I'm going to do is I'm going to put you into breakout rooms in a minute. And I think the presentation disappears when you go into breakout rooms. So somebody may have to take a screenshot of that. I'll put it up again in a minute. Okay, I'm just going to flick off. Okay, so what I'm going to get you to do is to consider what your preferred and differential diagnoses might be for Janine. So just a list. Diagnoses are essentially hypotheses, right? So the hypothesis that seems the most likely is your preferred, and differentials are other hypotheses that may explain that pattern of symptoms. Okay, so I just wanted to give you 10 minutes to go and chat in breakout rooms. I'm going to put you into 2 groups and have a think about preferred and differential diagnosis, and we'll come back and we'll talk about it. Okay, so I'm just going to randomly put you into 2 groups and then come back in 10 minutes. Awesome, everybody back. Cool, thank you for doing that. Oh, my slideshow switched off. Okay, so, I've lost it now. So we had 2 groups. So can I ask somebody from Abby's group, it doesn't have to be Abby, to let me know what your preferred diagnosis is for Janine?
Our preferred diagnosis was major depressive disorder.
Major depressive disorder, awesome. Okay, so we'll consider that as a first hypothesis. Let's Yeah, let's talk about it while we're on it. What were the main things that made you think it was major depressive disorder?
Due to her things like when she presents to the 3 month history of like her lowered mood, kind of that observational depressed mood. So she's been tearful, like her tearfulness. She's got like the weight loss, kind of like thinking about the criteria. Doesn't seem to be interested in much these days as well.
Yeah, anhedonia.
Yeah.
That's enough. Thanks, Abby. Thanks for that. I didn't mean to put you on the spot. But what you've got there is you've got two of the three things that we're looking for. One is the symptom profile. So she fits a lot of the kind of usual symptoms. You've got nice that you're thinking about mental state there when you're talking about her current presentation, but also things like weight loss and insomnia, anorexia, and all of those things, and anhedonia, as you said. They're all kind of major symptom profile of depression. You've also talked about the timeline. So of the three, there's the symptom profile, there's the timeline. So 3 months is well beyond the 2 weeks that we need for major depression. And then the third thing that you're looking for is usually functional impairment. Now that's a harder one to measure, but usually you'd comment on it and say, go through your tick list in your head as to why you chose that preferred diagnosis when you come to the exam. So symptoms, timeline, and functional impairment. Okay, so we'll go to the other group, which was Asha's group. Can you give us a list of your did you agree with that as a preferred diagnosis? I'm seeing some nods. Okay, what differentials did you have?
So yeah, that was our main one as well. And then we were also just sort of spitballing ideas about bipolar disorder. Obviously, she hasn't had any manic or hypomanic episodes, but could this be along those lines? We were thinking potentially a borderline personality disorder, with episodes of sort of like, it sounds like quite brief, intense relationships, obviously self-harm, and I guess she's got a lot of risk factors in her childhood for childhood adversity and things.
So when you say childhood adversity, what are you thinking? You're thinking around the bipolar, borderline personality disorder? Is that what you're thinking?
Yeah, I guess she's been either exposed to herself or through her mother to domestic abuse, and who knows what else in her childhood. So that's really good. That's really good thinking.
That's really good thinking, Asha. It is a risk factor. It's not in that kind of. So you really want to be thinking about the symptom profile first and foremost when you come up with your diagnoses. Some of the other stuff is more around your formulation and your causative stuff. But yeah. So but you've got it right. The brief, intense relationships there, and it may be that she's got a history of poor relationships, poor attachment, which, like you say, contributes to those kind of personality profiles. Okay, so anything else in your differentials?
We were just briefly talking about, like, I didn't know the criteria for them, but like any of the depressive states that can occur in or around pregnancy.
Yeah.
Because she's pregnant at the moment. So, like, I know they talk about baby blues, which doesn't sound very scientific. But
yeah,
I'm not sure what the proper term for that is.
Yeah, it's arguable. It's
just depression.
Yeah, it's arguable. I mean, you might call it a mental health condition associated with an organic condition. Is generally the broad term. So we generally get people to have. So I usually just say have organic condition as your coverall for everybody. It should always be a differential. In Janine's case, well done for picking up on that. Those things could all be a sign of pregnancy. There's people who are pregnant have a lot of those those issues. I've got 2 kids myself, so I know this. But there might be other things going on, thyroid conditions, for instance. There's a whole list, and on Moodle we've got I put an article on there about medical mimics, which are like organic conditions that can look like psychiatric conditions, so things worth thinking about. So yeah, all kinds of things, and capitalitis, all kinds of things. But what you want to do for everybody really is have a good full medical workup before you start, giving them labels of major mental health.
Yeah, absolutely.
So yeah, was there anything else that you thought you might want to rule out, or?
Probably, but I can't remember. Does anyone else?
Anyone else want to help him out? You've done well.
The only other thing that I mentioned, but it might be a bit of a stretch, was like something like PTSD. Just from it seems like she's had some trauma in the past, like Asher mentioned, and also to do with the pregnancy itself, because she was pregnant at 16 and it sounded like it didn't go too well, and now she's pregnant again. So I don't know if that would,
I think generally again, PTSD should be on your list of differentials for most people, because particularly in psychiatric populations, estimates go from between 50 to 100% of the people you'll see will have had major trauma in their lives. So it should, not everybody has a current active, meets criteria for PTSD in the classical sense, but often they're kind of complex trauma that people have. So I think it's a good differential to have for most people. Anything else? Any other differentials you had? Or actually, let's go back to the other guys. Let's go back to Abby's team. Any other differentials you guys had?
Anxiety.
Sorry?
Anxiety.
Anxiety, yeah. Could be any form of anxiety. I mean, the way we get you to list them is we say preferred, like it's the only one you can have. You can have a combination of diagnoses, obviously. So it could be depression secondary to anxiety. Any form could be generalized anxiety. Doesn't seem socially anxious, but you just don't know at this stage. Anything else you might want to rule out? There's one really important one that we've missed.
Could it be like a substance induced?
Boom, nice one, Bronson. Yeah, that's substances are, like PTSD, incredibly common. People don't always tell you about them either. People often know that they shouldn't drink or take drugs or whatever, and they don't necessarily want to tell the doctor. So it's something you should always have in your mind to be checking out. We do know a little bit about Janine in terms of substances, in the fact that she took 12 sleeping tablets. So my question would be, where did she get those from? Are they hers? Are they prescribed? If they're not prescribed, that massively increases the chances that she's taking something else illegally. Did she take it with alcohol? What's going on? So substances are really important. There's a few other things you might chuck in there. Just to come back to bipolar affective disorder, I think that's a really good one to think about in terms of people often present with the depressive symptoms. They don't often say, oh, and by the way, 3 months ago I felt fantastic and I was up all night working and pissing off all of my family and bought a car and all of these kind of things. They'll often talk about the depressive stuff, so you sometimes have to dig a little bit for the hypo and manic, hypomanic and hypermanic episodes. So yeah, and then possibly some other things. We'll come to our list in a moment, but generally the process you're going through is you're trying to say whether or not your preferred diagnosis fits in terms of those 3 elements. So symptom profile, Timeline is really important because if it's some kind of psychotic illness, you really need to think about, whether or not it's schizophrenia or some kind of brief psychotic episode. Really important to see if it correlates with any substance abuse, for instance. Same in terms of depression versus adjustment disorder versus those kind of things. Timeline is really important. Functional impairment is something that we do. I don't think you'll fail if you don't talk about it, but it's one of the three things that we're looking for, really, in terms of how you decide your diagnosis is good or not. I won't get you to answer this question, but the thing you need to be thinking about is a diagnosis is just a hypothesis, so you don't know for sure at this stage. So there might be more information you'd be looking for. So when you present at Viva, you may say, I had a suspicion that she's got some autistic features. She's presenting with autistic features, not necessarily Janine. This is an example. But I'd want to do, proper ADOS testing or ADI testing, or ask a psychologist to assess them, or whatever it is you wanted to do. Same with intellectual disability. You may not be able to decide then and there, but it's just think about what you do, or, would I do blood tests for organic conditions, or whatever it might be. So think about how you clarify your diagnosis. Also think about if there are things that really don't fit with that. So if you're thinking major depression, but she's talking about hearing voices, how does that fit with your preferred diagnosis? So you've got to think about the evidence that doesn't fit. It's really easy to just, focus in on your preferred diagnosis and miss the things that don't fit. Right, so I'm going to come to my list in a minute, but I just wanted to reflect on why we make diagnoses at all, because the world of difference teaching you're going to have often reflects on the fact that diagnosis wasn't helpful for some people, and they found it very reductive and very labeling of them, particularly things like borderline personality disorder. That can really change how people are treated and how people are seen. And so there's some arguments in psychiatry and psychology that the diagnosis actually isn't helpful for people. So why do we teach it? Well, I mean, the main reason we teach is it gives you somewhere to start from. It gives you an idea of, it helps you know what are the things that generally help people with these kind of issues. So be that medication, be that CBT, you've got to start from somewhere. But what we're trying to do in TI year and beyond is to get you to think about, rather than just focusing on the diagnosis, that doesn't explain all of who somebody is. We're trying to get you to formulate and think about the whole of that person. So just because the formulary says a particular, or NICE guidance says a particular therapy will work with depression, so CBT may work with depression for a lot of people, but it may not work for this particular person because of who they are. So that's what your formulation is about. It's trying to individualize it to that person. So it does give you it is a tool, but it's a very blunt tool. So this was the list that we came up with, which kind of pretty much you covered everything. There's a couple questionables at the bottom. So so we got some organic conditions which you want to think about, other mood disorders, so anxiety, including PTSD, bipolar affective disorder. So these are things you're ruling out effectively. Substance abuse disorder, personality disorder, query borderline. Again, some of the more major mental illnesses like personality disorder and psychotic disorder, you wouldn't give those diagnoses lightly, or you wouldn't even talk about them lightly, because they can really change how people are treated. So it's one I'd encourage you to be sure about if you're going to use it as a preferred diagnosis in your exam. We've also got psychotic disorder, not that there's any real obvious features of it there, unless there were some negative ones. But it's one you want to have in the back of your mind. And eating disorder, just because you talked about some anorexia and weight loss. Again, doesn't seem obvious, but people, again, don't always volunteer information about anorexia, and particularly bulimia. They're often quite secretive about their behaviors. And the last one is no mental illness. This may just be normal experience of life. and there was a really interesting psychology study where I think it was a psychologist checked themselves into a mental health ward in the States, and then listed all of the diagnoses they came up with. They were perfectly mentally well, but they were diagnosed with a whole raft of conditions by the end of it, because when someone's in those environments, we expect them to have mental health conditions, and we're almost looking to give them a diagnosis, which is kind of the process. But sometimes, it may just be reasonable reaction to normal life events. So you need to think about that. Okay, and as I put at the bottom, you just need to think about how you'll rule those things in or out. Examiners may ask you, so you said it, you thought it might be hypothyroidism. How would you check that out? You know this stuff, year 6. So this is just a little reminder. A good way of reminding you what your differentials might be is to think about ICD-10 and how it's structured. So we've got the F0 organic conditions, substances, psychotic, mood, and neurotic. Not that we use those terms particularly anymore, but they kind of give you if you have those 4 and potentially the 5, which is the F5, F6, F7, if you have those 4 to 5 categories listed as your preferred and differentials, you've probably got it covered. So some organic, something substance, something psychotic, something mood, something neurotic, which is kind of anxiety, in case you weren't sure, that's kind of anxiety disorders largely. Okay, that's just as a guide. So that's diagnosis. We're going to talk a little bit about formulation now, which you've done in 5th year, and there are resources on Moodle to refresh you on this, some of which you will have seen in 5th year as well. But essentially what a formulation is trying to figure out why this person is presenting with this problem in this way right now. Oh yeah, so obviously the reason that's there is because it's the tip of the iceberg. You don't know everything that's going on, but you're just trying to make a guess at why they're here at the moment. So a formulation basically has 3 components in the way that you'll do them. As a psychologist, we often do fancy big formulations with diagrams and all kinds of strange things. But for your level of training, what we're really looking for is just something that links the 3 concepts of what happened in the past. So what happened to them when they were young and earlier affected how they thought about the world. What happened to bring them here today. So as presumably, I don't want to do your job for you. I'm not going to tell you, Janine, I'm going to get you to do this in a minute, but something has happened that was really important to her that made her want to kill herself, right? So often we'll have people present at ED who've tried to kill themselves over a relationship breakup, but not everybody who has a relationship breakup tries to commit suicide. So what was it about a relationship breakup that was so awful to them that they wanted to end their own life? That's what you're trying to get at. You're trying to say, okay, maybe this person had a lot of abandonment in their life, people abandoning them, parents walked out, I don't know. And then this relationship breaks up and they can't deal with the abandonment, and so they blame themselves. They say, it's not worth it. I'm awful and no one's ever going to love me. So they try to kill themselves. So that's what you're trying to do. And then you're looking at what's maintaining that. So might be social factors. Might be they've got no money. Might be a whole heap of things. Might be things that they do, like taking drugs. So you're looking at what happened in the past. What was it that happened recently to make it happen, to make them present to services, and what keeps the problem going. So you should remember some of this from 5th year. But in 6th year, what we're trying to do is get you to integrate those a little bit more. So try and link those across in the way that I've just done. Like I say, this person's got abandonment issues due to their childhood, and the breakup of the relationship triggered that, and they have maintained the problem by drinking heavily. It's just an example, obviously, but what you're trying to get you to do is link over time. I'm trying to point to, how you treat this person. So do you work with their thoughts in terms of cognitive therapy, or do you work with, alcohol the alcohol and drug use, or do you maybe work socially if it's to do with social isolation or poverty or whatever it might be? That points to things you can do to make it better. So that's the idea of the formulation. Now, ideally, this should be a shared understanding of the person, as in you sit down with the client and you say, hey, does this explain? Does this fit for what's happened in your life? And psychologists have the luxury of lots of time with people, so that's what we often do, because we want them to understand why we're recommending the things that we're recommending. That's not always possible for a TI because you see people so quickly, but ideally it should. That's the best way of knowing if it's a good formulation, is if the client agrees with you. Well, that's not always true. Sometimes people totally disagree, but they're wrong. No, I'm being flippant. All right, so I'm going to get you to think about Janine again, and I want you to do a little bit of a formulation for Janine. Now, I'm not expecting this to be polished. You've just got 10 minutes. I just want you to have a think about her and think about the things that happened to her in her past that may have kind of led her to be where she is. You might call those predisposing, and then the precipitating event, that kind of events that caused her to become particularly unwell and present services now, and then maintaining is the third one. You may also want to think about protective factors, the positives. That's the 4P approach, but mainly I'm just trying to get you to think about Janine's story. So you should still have that. Hopefully someone took a screenshot, but I will. I'm going to put you back into breakout rooms for another 10 minutes, and I'll come back and we'll have a chat about it. Like I say, not expecting it to be polished, but if you could select one person from your group to feedback, and then we'll just talk through it when you come back. All right. All right, welcome back, everybody. Okay, so because Abby's group was so keen to come back, they came back super fast. would somebody from Abby's group, whoever you've nominated, share the formulation you've got for Janine? Let's go back to there she is. Just tell me what you thought. It doesn't have to be too polished.
So we've kind of brainstormed some ideas under the headings. So I guess for predisposing factors, but that her exposure to abuse when she's younger can increase the risk of having some unstable relationships later on. And so I was not having like a maternal paternal figure to look up to when she was younger can increase the risk of that as well.
Mm-hmm.
And her mother having depression when she's young may increase the risk of her develop depression as well in terms of genetics. And these are like other factors, that she's being socially isolated at school and her having some brief intense relationships when she's younger. So those are the things like the predisposing factors we've come up with.
Yeah. Okay, so I'm gonna, rather than go through the list, I'm gonna ask everybody in the group, how do you think that shaped her thinking about herself and the world and other people? What would that background history, what would that have made her think about how life is or who she is? Tricky question.
Really, like a lot of lack of safety around forming supportive relationships.
Yeah, so people are unreliable and will let you down.
Yeah, and seeing abuse and everything, and yeah.
True. Yeah, people might let you down, but they might even hurt you. Yeah.
And you can kind of see that, I guess, a bit with her healthcare interactions. She's like not very engaging, or sees it as quite negative.
Doesn't trust people, right? Yeah, in a nutshell. Anything else? How would she feel about herself, do you think?
Not great.
Yeah.
Okay, it says low self-esteem. She really doesn't feel worth much, or all those kind of negative thoughts around that.
Yeah, and what we know about people in general is, I mean, if anything goes wrong, when things go wrong, human beings tend to blame ourselves because we feel like we can learn from things. That's how we evolved to try and learn from events. So we tend to blame ourselves when things go wrong. So when people have bad lives, they often feel it was somehow their fault. So she's not going to feel very good about herself, but she's also not going to feel very good about other people, that other people are likely to hurt her, and she may not be able to protect herself. Okay. There's some other things, but that's a good start. So what? Let's go to the other group then. What precipitated this? What kind of made? What's the main thing, and why was that important to her, do we think?
We said that the main precipitating factor that we found was that her boyfriend broke up with her, and that was probably so significant because they'd been together for 6 months, and she finally, after being a single mum for so long, probably felt some sense of stability and had some social support and a partner, and that's all kind of gone. And I guess it kind of almost an element of PTSD. It's not the first time she's been abandoned, or somebody she cares about has left her. Yeah,
great. Yeah, so it's triggered some stuff from the past, right? That's what we're trying to get at. Yeah, I mean, you're dead right. I hadn't thought of it in that way, but there is a big social support for somebody. How many she's got? She's got a daughter who has been seen by services, and she feels like people think she's a bad parent, and she may have felt, maybe she did believe that she wasn't a very good parent. Maybe she's not got great experiences of being parented herself, so maybe she feels like she's turning into a mum in some way. And maybe that social support from the boyfriend was the thing that made her feel that she could do it and she could get through. So that's really good integration you got there. Really good. Thinking about it. Now, was there anything else that you think's important in this? We haven't really talked about maintaining, or sometimes we call it perpetuating factors. You may have heard of the 4 Ps model of formulation. It's a bit tricky to draw it out from this, but when you're working with your people on placement, you'll be thinking about what are the things that keep this going. You could argue something like self-esteem is an issue. Social support is definitely something here. Don't know if there's anything else. Is there anything else that leaps out at you guys in terms of those 3 factors: the past, the recent, and the past, the precipitating, and the maintaining factors?
For maintaining, we also talked about how the daughter's always sick.
Yeah.
And because she's a single parent and she's quite young, she probably has a low socioeconomic status. So that's going to be another social factor.
Yeah, we don't know if she's working, do we?
Mm-hmm.
We don't know if she's. The other thing is, so when we so this is the formulation, but the formulation for the exam, the question is, tell us about the cultural, social, and psychological factors that are important to this person. And we haven't talked at all about culture. And I always think it's funny when we present them like this, and we start with Janine is a 21-year-old of Maori descent, and we haven't talked about culture at all. And it would be really interesting to know, what is her relationship with her identity and her culture, and does she have support from the marae, or has she disconnected from that? That could really be a maintaining factor if she's isolated from a culture. And it's just tough being a single parent. There's no doubt about it. And she could see. So what you're trying to figure out is, why was it so bad that a partner left her, if that's a precipitating thing? And it's obviously that she feels like she's not coping as a parent. presumably she doesn't have enough support to do so, and she feels like, you know, I'm pretty crap at this. The world will be better off without me, or my kids will be better off without me, maybe. So you're trying to guess what's going on in that person's head when they try to take their own life. So that's what you're trying to do, is you're trying to just come to that understanding. Now, for your written formulations, there is some stuff on Moodle which I will take you to now. Get out of this. Come back to that in a moment. Not that one. Where is it? Yep. So on Moodle, which the trouble is when you're on Zoom, it sort of minimizes you. Okay, so you've got the slides from today, which you can look back on. You've got something on risk assessment in psychiatry, which has got a kind of a list of activities you can do. Where is it? So that's risk assessment. So there's some little videos for you to watch. Ministry of Health guidance, another little video, chapter on risk assessment, and some stuff from Orangutan Mariki. But when we come to formulation, we've got some basic chapters and basic structures for doing formulations. And we've got the RANZCP clinical examinations formulation guidelines for trainees. So there's some good stuff there to help you think about what your formulation would look like. So do look at those. And then that's just an article, which is this one, on differential diagnosis with organic conditions. So just a mention of that. But just to go back to this, so you've all got the right idea. You're all on the right lines. You can basically, what you're looking for is to take the list of ingredients. So you're looking at the, I wouldn't encourage you to overly dwell on the biological aspects. So genetics you can mention, but it doesn't really contribute to how you formulate somebody. It's good for helping you figure out your diagnosis. So if someone has a family history of schizophrenia, there's an increased chance that they'll have schizophrenia. So it's useful for diagnosis. It's not particularly good for helping you figure out someone's psychology. But spiritual, cultural factors, psychological factors, which we just talked about, and social factors really are. So those are the 4 ingredients. And this is a matrix for a formulation. You know, you've seen the 4 Ps. We haven't talked much about protective factors. Protective factors aren't great for helping you understand the problem, but they are good at helping you design a solution. So if the kids are a major source of, or say work is a major source of self-esteem for somebody, but their mental illness is keeping them out of work, then you might look at strategies to get them back into work, for instance. Or so it's really good for helping you design solutions and interventions. But it's the predisposing, precipitating, and perpetuating of the things I'm going to help you design an intervention. So that's one way you can do it as a box, just to tick them all off. And then, but that's not a formulation, that's just a list of the ingredients. So you need to kind of weigh the ingredients, see what's most important, and put it all together to bake it into a coherent whole. So use the stuff on Moodle, and that'll help you get that right. We're only looking for a page formulation. We're not looking for 10 pages. So it's just a pen picture of this person, and we'll get you to talk about it in the exam. And in the exam, like I say, it's cultural, social, and psychological factors. You can do it any way you want. I personally think it's best if you do it in that order. So start with cultural, because it's relatively easy to talk about. Don't assume that just because somebody's not Maori, they don't have cultural things to talk about. So I'm English. I'm separated from my family who are all overseas. That might be an important factor. It might be that you are a stereotypical Kiwi tradie guy, and your culture of your peers is to not talk about your feelings. That's an appropriate cultural observation as well. They can be stereotypes, and you've got to be a bit careful of not not being discriminatory in your thoughts about that. But they can be clues, right? They can describe a person, but they're also important in terms of how you intervene, particularly if somebody's disconnected from the culture. Okay, yeah, start with culture. Social's relatively easy to talk about because you can kind of list things like social economic factors, poverty, lack of employment, all those kind of things, social isolation. And then the psychological bit is the bit we've just done, which is a little bit harder to do and harder to be sure about. So it's good to build up to it. So I'd recommend you do it in that order, but it's totally up to you. Here's an example of a formulation which wasn't done by me. There's good bits and bad bits about this, but I'll talk you through it. So Janine's mother suffered from depression, perhaps increasing Janine's genetic vulnerability. In early childhood, an absent mother and several different caregivers with limited commitment to providing a consistent, stimulating environment may have contributed to a sense of abandonment. That was the stuff we talked about, not trusting people, and potentially feeling abandoned. Seeing a mother used by a series of men may have left Janine feeling insecure and convinced she too will be unable to resist such abuse. Added to this, Janine's experience in childhood was of insecure attachment and abusive adult interactions where women were devalued and abused. So again, sense of who she is in this. Modeling this, Janine struggled in her early adult interpersonal relationships at school and intimately. This is an interesting part. The move from her marae when she fell pregnant may have alienated her from her cultural heritage at a time she needed its support the most. Her limited parenting skills and fears that others are judging her parenting skills may reflect her own lack of being parented. Janine may fear that if she acknowledged this, she would lose custody of a child, distancing her from proffered help and exacerbating her interpersonal functional problems. These vulnerabilities were compounded by the loss of her current partner and the fear of managing another child and possibly losing both parents. This led to a suicide attempt and subsequent presentation. So what this person, their formulation is about that fear that she's not a good enough parent and not coping and not able to reach out for help. Where does it say this? She may fear that if she acknowledged that she's not a good enough parent, that child services may take the child off. That's a common fear. You don't want to say, actually, I'm not coping, just because then people might say, oh well, we'll take kids off you. And so she's distancing herself from help, and then the one source of support that she had was a partner is likely to make her cope less. So that's that person's formulation, which formulations are a bit subjective, but they've got to make sense, right? I mean, and that does make some sense in terms of who she is and what's going on for her. So this is from CBT. This is a CBT formulation, just as another way of saying it. So there's this idea that you have your early experiences. Here's an example of a person who's a high achiever, and the parents demanded high standards. You're all doctors, so maybe you're all high achievers. And perhaps they felt that the only way they could be good enough was to achieve. So then you develop these thoughts about the world, like so we call these beliefs and rules. So I must be perfect, or I'm useless, or I'm a failure. And if I have to do everything perfectly, and then something goes wrong, so that's your predisposing. That's your history, and that's the predisposing thoughts. And then you've got something that kicks that off, like failing an exam or a breakup of a relationship or loss of job, that not being perfect. So therefore you're a failure. And that starts certain thoughts like I'm useless, I'm no good, starts feelings of anxiety or depression. And there might be things that you do like drinking heavily or avoiding people that make it worse. So it's just thinking about those three factors. They're important. Okay, so that's formulation. Like I say, there's stuff on Moodle to help you with that. Management plan. Sorry, I've got a bit of a dry throat. Just have a drink of water. So for your management plan, we're not going to talk too much about this because you'll see a lot of this on placement, but it's good to think about immediate, short-term and long-term. Often people will think about, if they see somebody in crisis services, what they're going to do tonight to keep them safe, or what they're going to do. So it might be, I'm going to admit them. And you go, okay, right. And what are you going to do then? and that's what we need you to think about is, in the next, they'll come into the ward. What are you going to do with them on the ward? When they're going to discharge them from on the ward, where are you going to discharge them to, and with what supports? So short-term, immediate, short-term, and long-term. And you want to think in those 4 areas. So medical management, psychological management, social things you'll do to make this person's situation better, and spiritual and cultural supports that they might need. So this is a slide. Do you have a diagnosis that's more affordable? The doctor is asking. And the reason we put that in is basically because DHB services are very stretched. They aren't always able to provide the best services. And I'm particularly thinking about psychological therapies here. There's a real shortage of psychologists in New Zealand at the minute, and a real lack of access to talking therapies. So what you may see may not be best practice. So you may see that people are treated largely with medications, particularly on some of the wards. But actually, what I'd recommend you do in terms of your Viva is talk to what they should get, what you would recommend that they should get, not what they did get. And the best way to do that is just to look at the evidence, look at what is the first line treatment for whatever preferred diagnosis you're recommending. So if it's depression, you're looking at SSRIs and you're looking at CBT, and so on. So just look at what the evidence is. They may not have got that, and there may be good reasons for that. So if you come along and you say, my preferred diagnosis is major depression, and this person was prescribed olanzapine, we'll kind of look at each other and say, well, why? So you need to be able to say why. There may be a good reason for that, but you need to tell us. And if it was your consultant made that decision, you need to ask your consultant, so why did you give them that and not an SSRI? And they may say, well, they've been tried on SSRIs, but we as examiners don't know that. You need to tell us, else we'll think, why on earth are they giving that particular thing? For psychological therapies, again, it's good to look at what the evidence is, but we don't expect you to be experts in these things. It's okay to say, I think it would probably be this, but it's complex, so I'd probably talk to a psychologist. Or saying with medication, I think it's probably this. I'm not 100% sure why that was chosen, but I've spoken to the consultant. Well, you might be a bit clearer on that. We want you to understand why. So yeah, so try and say what they should get, not what they did get. All right, so this is my last slide. So you get a little bit of break before the World of Difference team. But here's just a list of top tips, things to remember. And like I say, there's stuff on Moodle, and these slides are on Moodle, so you can have a look at them again. So the Vivas are very tough, and it's typical for several people to have to resit. That seems to be better with the things we put in place, like the things on Moodle. And I did mention there is a exam practice tutorial which one of the registrars runs, which is just a good example for you to get feedback on how you're doing. Use supervision tutorials to help you prepare. Preparation and practice is the key, so I would seriously think about writing a little script for each of the headings for diagnosis and preferred and differential diagnoses, for risk, and so on. Prepare. Just prepare. So diagnosis, I'd say always consider organic factors, substance abuse and trauma as potential differentials, because they happen all of the time. And one of the things we don't want you to do is to miss things. So give somebody a diagnosis of borderline personality disorder when they've actually got encephalitis. I don't know, that's a bad example, but we don't want you to miss things that are important. For safety, this is really think about safety and how you describe it, because people often fail. There's no fail, there's just a reset and redo, but people often need to reset because they miss things out. So it might be that somebody presented as suicidal, and you talk a lot about the risk to them and how likely they are to take their own life, but you haven't thought about the risk to other people. And you just need to name check it. You just need to say, well, there doesn't seem to be any history of violence. There doesn't need to be any risks to other people, as far as I can tell. So long as you've said it, then we know you've thought about it. But the other thing is to think about, so in Janine's case, what are there any risks to her children? You know, she's tried to commit suicide, she's come into the ward. Where are they? Who's looking after them? What's going on for them? So think a little bit wider. So think about risk to self, risk of violence to others, but also risks to dependence and vulnerability to the person as well. A lot of our clients are very vulnerable in the community. Okay, so formulations, we talked about that, cultural, social, and psychological factors. So talk about the background factors that led to your client to present services and are maintaining the problem in particular. And I've given you a couple of good phrases there where you try and link the facts. These are, again, hypotheses, you don't know for sure. So you'd say his abuse by a teacher may have led to feelings of mistrust of people in authority, and he's tended to avoid interactions with services in the past. That's a good formulation line. His experience of being assaulted may have led him to feel vulnerable to future attacks. So it's possible that he joined a gang in order to feel powerful and safe. You're making hypotheses, you don't know for sure, but so they may have, you don't know for sure. It's possible. And then your management should flow from your diagnosis formulation. So look at the evidence, look at NICE guidance or wherever you go for your evidence-based therapies. If your preferred diagnosis is social anxiety, then you look up what the first line treatments are for that. And if they've had the first line treatments, then you think about what second line treatments are, and so on. But it should be individualized. So if people have particular physical conditions that stop them taking those first line treatments, then you take that into account, right? And that's where your formulation comes in for the psychological and social treatments. So that's it. It's going to be I feel quite breathless. I've gone through that really fast. Like I say, there's lots of stuff there to help you. Hopefully your placements will be good, and you'll get lots of chance to see this and discuss this with your supervisors. And just I am not examining this time. It will be Greg Spencer is the lead examiner, plus a psychiatrist who works locally. So I may not see you before the exam, but do let us know if there's any problems with the assessments. Yeah, I think that's about it. Is there any questions at this stage? No, you're probably all like, whoa, he's just talked at me for an hour and a half. It is a quick run through. The stuff's all there on Moodle for you to go back to if you need it. But mainly just good luck, and Kerry will be in touch with various things about the tutorials. She may already have sent those. And like I said, there's an extra tutorial which is optional for you to practice before the exam. Any other problems, let Kerry know as soon as you can.